ACLM, welcome. My name is Kelly Freeman. I'm the Director of the Workforce Development here at the American College of Lifestyle Medicine. Welcome to this webinar on integrating lifestyle medicine into the care of older adults. We have three esteemed experts in geriatric medicine, Drs. Susan Friedman, Anna Fall, and Kamal Wegley, who will be presenting. For those of you who might be new to lifestyle medicine, this is a rapidly growing healthcare specialty that is built on 6 pillars or domains, which include optimal nutrition, physical activity, restorative sleep, stress management, positive social connectiveness, and the avoidance of risky substances. The learning objectives for this webinar include describing the synergy between geriatrics and lifestyle medicine and how their combined principles can enhance patient outcomes, connecting the age-friendly health system's 5M framework with core lifestyle medicine domains, identifying key features of geriatric lifestyle medicine, and finally listing practical tools and clinical resources to support your work with lifestyle-focused care for older adults. Today's presenters are Dr. Susan Friedman, geriatrician and researcher from the University of Rochester in New York, Dr. Anna Fall from Traeger Institute's Optimal Aging Clinic at the University of Louisville in Louisville, Kentucky, and Dr. Kamal Wegley, geriatrician and lifestyle medicine expert at Hackensack Meridian Health in New Jersey. And we're going to start with Dr. Freeman, but first I wanted to give her a shout out that just last month, Dr. Freeman's long anticipated book about lifestyle medicine for the older adult was released. So sending a huge congratulations to her and to all of the book's authors. And so now let me introduce you to Dr. Freeman.
Okay, well, thank you. Thank you for this opportunity to talk about geriatrics and lifestyle medicine. Yes, the book is really a labor of love that was put together by many authors, and hopefully is a useful reference about this whole topic. So we thought we would start with some basic concepts in geriatrics that I think are useful when we're thinking about geriatrics and lifestyle medicine. And that has to do with, first of all, squaring the curve, and then thinking about promoting healthy aging for everyone, and then a geriatrics framework called the 5 M's, which I'll discuss in a minute. So this idea of squaring the curve or compression of morbidity is a concept that's been around for over 40 years now. It was first written about by James Fries in an article that he published in the New England Journal of Medicine. And he really talked at that point about the goals of healthy aging, really. And what he suggested is that, we all want to live our best lives possible for as long as possible, and then at the end of life have a quick decline and then pass away. And his concern at that time in the early 80s was that if we don't do something about the onset of chronic disease, that we're not going to be able to push that curve to square it off. And what we have seen in the past several decades is really earlier onset of chronic illness, so that for people who are 65 and older, 90% have some chronic illness, and over 2/3 have more than one chronic illness. Next slide, please. So, the question is, what do older adults want? And when this has been looked at, really, so this was a survey of 27 different studies that have been done around the globe. looking at what people want from healthy aging. And really, when people are asked about it and how they define healthy aging, it really has to do with things like remaining engaged, having a sense of perspective and self-awareness, and remaining independent. Those are really the top components when when older adults think about healthy aging. Another framework that has been used in many, many studies is this framework of successful aging. And I'm not crazy about the term. It suggests that, there are people who are successful and others who are not. And I think there are many things that go into how we're able to age. But Jack Rowe, who's a geriatrician, and Robert Kahn, a gerontologist, got a MacArthur Foundation grant to look at what they termed successful aging. And they really looked at three different components. The first was avoiding disease, the second, maintaining high cognitive and physical function, and the third, remaining engaged with life. And clearly, we know from other research that avoiding disease or minimizing the impact of disease really do impact those other two components. So it's a critically important piece of this. The American Geriatric Society, about 6 years ago now, put together a white paper on healthy aging to describe what we mean by healthy aging and to recognize that the older adult population is extremely heterogeneous. So that from very high functioning to very, very low levels of function. And what this white paper tried to outline is that really there are opportunities at every point on one's lifespan to promote healthy aging, whether it's through primary prevention or preventing things from happening in the first place, to secondary prevention, to which is reducing the risk of recurrence, and then tertiary prevention to reduce the functional outcomes of chronic illness. And this framework maps those levels of prevention onto these 5 different domains that were put together in I think, an important paper put out by Health and Human Services called Healthy Aging in Action. And those domains, really do map onto that concept of successful aging that the Rowe and Kahn model. More recently, the 5M model of age-friendly health systems has really come to be an important framework for healthcare systems. And this was really an effort of the John A. Hartford Foundation, the IHI, and the American Hospital Association, and Catholic Health Association. And the idea of this was to really have a foundation for optimizing health for older adults, understanding that healthcare for older adults is very complex, but to really make all care of older adults age-friendly, based on evidence and the dictum, first do no harm, and wanting to align with patient goals and their family goals. So the 5 M's in the 5M model are first thinking about what matters most. So being guided by, again, patient goals and preferences, focusing on mind, mobility, medications, and multi-complexity. And this really intersects well with lifestyle medicine. So I think the 5M framework really uh, gives a way of focusing what we're trying to do, excuse me, in lifestyle medicine. And similarly, lifestyle medicine pillars can really impact all of these different outcomes. There was a really great book chapter in the most recent Dr. Rippey's lifestyle medicine textbook put together by Dr. Jen Muniak and Dr. Paul Mulhausen, looking at the shared principles and approaches of both lifestyle medicine and geriatrics. And what they suggest is that there's significant overlap. So the goals of healthy aging and optimizing function, again, sort of being focused on patient goals or what the patient's priorities are, the importance of being evidence-based, the ability to have complex and holistic thinking, so taking the whole patient and their surroundings into account. Appreciating low-tech and high-touch modalities and trying to minimize the adverse effects of medications and procedures. These cognitive models like the 5M model and the 6 pillars of lifestyle medicine. And I think a recognition and a respect for the degree to which systems really impact outcomes. And so really thinking about developing optimal systems to impact those outcomes. The use of interdisciplinary teams and the idea of triaging and trade-offs that, again, focusing on what matters most to the patient and using that as a guideline. And then more recently, Dr. Wagle and I put together a chapter looking at the rationale for lifestyle medicine in geriatrics. And that center part is the overlap that that I just mentioned. But then there are some differences in terms of how lifestyle medicine and geriatrics put things together. So, for example, both using interdisciplinary teams, but the interdisciplinary teams may look somewhat different and have different specialties that participate. Using different tools to screen and using lifestyle prescriptions versus medications and procedures. And with that, I will turn it over to Dr. Fall, who's going to be talking about a practical example of geriatric lifestyle medicine clinic.
Thank you, Susan. I appreciate this. And thank you for the opportunity to share a little bit of my experience over the last 10 years in trying to integrate all the principles of age-friendly healthcare into lifestyle medicine approaches. So before I start, just to align things a little bit in how I was trying to conceptualize this integration when we started our clinic. So the 5 M's of age-friendly care, what matters most, really aligns with all the pillars of lifestyle medicine. And then the multi-complexity also is really embedded in all of the pillars. Medication is focused in terms of the pillars, the avoidance of risky substances, nutrition, and physical activity. And then the mind is aligned to stress management, restorative sleep, and positive social connections. And mobility, lastly, is connected to physical activity, nutrition, and restorative sleep. So you see there's a nice integrative way in which we can align these constructs with each other from these two ways of looking at care. Next slide. So this is a picture of our clinic. This clinic was built in 2019. We started an institute at the University of Louisville in 2015, where I was asked to bring together all the disciplines across the university to create something that can make a difference for the aging population. We were also the city that had the most long-term care facility headquarters in our city. So they felt it's a very strategic move to put some resources down to support this idea of working together to create something special for older adults. So over the first 4 years of that journey, we work hard on getting donors together. And in 2019, we were able to build this space out that we're calling the Traeger Institute and the Republic Bank Foundation Optimal Aging Clinic. The Institute is the research arm and the university arm of this initiative. And then the clinic is the practice side, is where we can practice these innovations. It's part of an academic healthcare systems. So it's all working together, but it's really two systems who came together, the academic side and the clinical side, to create this clinic. Next slide. So in 2020, after we built out the space, I became board certified in lifestyle medicine. And well, both me and one other colleague, and we started the journey of integrating this work into age-friendly healthcare. So in order to do that, we have to, like Susan said earlier, create a different team. It was not the normal team that we originally had, where you have a geriatrician who's doing the specialized care, and then a nurse practitioner who helps us with the primary care. We knew right off the bat that we needed licensed clinical social workers in our space. We also needed clinical social workers to do the care navigation. So they became part of our team. And recently we added community health workers because we were able in the state of Kentucky to get reimbursement for community health workers. So they're focusing on the resources and social support. Pharmacist was added to this equation this year because the system realized the value of having better medication management for older adults. After years of advocating for it, they gave us pharmacists who's in our space once a week. We have a whole physical therapy practice connected to our space. Well, it's right there in our building, so that we can focus on movement. That's such a big and important part of a healthy older adult and an age-friendly healthcare system. And then this year we opened up a culinary kitchen where we are teaching medical learners, social work learners and nursing students healthy nutrition, and also how to convey that messages to their learners, to their patients. And we are also doing community classes, and we are working with patients with specific diseases and treating them in healthy cooking. We have a nurse practitioner who is trained in culinary medicine practices and lifestyle medicine, who is running this part of the work that we're doing. And then we have a registered nurse and medical assistants who are our support staff, and a lab technician is also right there in our space. So this is our team. This is the team who work together, who are doing this work. Next slide. This is just some pictures to show you our room where we do all the visits with the physicians. Sorry. And then we have the annual wellness visit room. That's a dedicated room. You can go back one slide. Thank you, Kelly. Where we do the annual wellness visits. On the bottom, you see our therapy room, and the Quest lab is at the bottom right. Next slide. Now, in order to do really lifestyle medicine correctly, you need more than what I just showed you. So we have additional wellness service team that we have in our space as well. We have a Tai Chi instructor that's doing Tai Chi twice a week. We have a yoga instructor who's doing yoga twice a week. We have a massage therapist who can do massage therapy in one of the rooms. We have an exercise physiologist who's doing exercise coaching. We have an artist who's doing art classes with older adults. We have chefs who's doing some of these cooking classes. We have older adult volunteers who's running a social club. Then we have law school faculty and students who's running a law clinic that we very soon realized early on in our work that that's really such a need for older adults to have that guidance in terms of their wills and testaments and health surrogate and living wills and all of that. So these students and faculty provide that. And then social work faculty and students are doing some drumming with patients. And there's one thing here at the bottom that I now cannot see. But in any case, I don't know what it is. So just go to the next slide. This is an example of all of these things. And at the top, you see our art class. And then in the middle top, we see the exercise area. This is a class doing yoga at the end. And then in the middle, you've got Tai Chi. This is our social club there to the right in the middle. And then these bottom pieces are our kitchen. And there is the drumming. So these are all the things that happens in that space that we have renovated to do all this. Next slide. What's very important for us in our work, to do this work, we have to have technology integration. So we work with Epic. We have the normal Epic EHR system. We have an integrated MyChart where we do our assessments. Patients, whenever they come to us, they do these comprehensive assessments where we assess both their biological health, their mental health, and then also social determinants of health. That all, and I'll talk about that in a minute. Then we use the Epic Healthy Planet part to do the care coordination and planning and resources for our patients. And that's the care management piece. That's also very important, all integrated, that everyone can see what's going on in all of the areas of providing care for an older adult. Next slide. So this is how our workflow goes. We start with a comprehensive assessment for all patients that we have in our space, 65 plus. Then based on that assessment, we develop an individualized care plan. We do medication management. We also do behavioral health integration and care coordination, and then referrals and resource linkages where needed. And then we do a follow-up assessment and reassessment either every 6 months if there's brain health components involved, or every year we do the follow-up assessments. Next slide. So the self-assessment, that's we let each patient complete a self-assessment via MyChart before their visit with us, their first visit. So all new patients complete the Flourish Care Index, and you can see to the left, this is published in the Gerontologist. They do a self-assessment of their biopsychosocial health. The Flourish Care Index embeds both the 5 M's and the 6 pillars of lifestyle medicine. So we find out everything we need to know to address all of those pillars. The Flourish Care Index measures the vital signs required for a lifestyle medicine approach: physical activity, diet, stress, sleep, emotional well-being, tobacco use, alcohol consumption. It's all part of the Flourish Care Index. Next slide. So the annual wellness visit, all patients 65 at our clinic must have an annual wellness visit on file. And the Flourish Care Index are used as part of the annual wellness visit to replace the health risk assessment. That's a requirement that has to be completed. The clinical social worker and the registered nurse are mainly responsible for completion of the annual wellness visit. And all of these visits end with a care plan that's designed within the care management part of Epic Healthy Planet. All annual wellness visits end with a referral to a variety of services, resources, and preventative care. And everyone has, most of the time, a referral to one of the services that's aligned with one of the lifestyle medicine pillars. Next slide. The medication reconciliation is part of the annual wellness visit. And as you've recalled, that is one of the pillars of lifestyle medicine. One of the pillars of, it's both lifestyle medicine and of age-friendly healthcare. In complicated cases, the pharmacist at the clinic will prepare a comprehensive medication management plan in coordination with the geriatrician if needed. And we see that a lot coming up where this is very much needed. Next slide. We have an integrative primary care and behavioral health space where the clinical social workers are doing behavioral health consultant work, and the LCSW support the primary care, and the geriatricians of integrated behavioral health services. Very different from the traditional siloed model. It's all integrated. So we are able to provide right on the spot help and support for anxiety and depression and loneliness and isolation. Next slide. And then we have the strong focus on social determinants of health, that we connect patients with resources, we connect them with healthy eating. We have a food pantry in our space if that's needed. We have, as I said, the exercise is there. We help them with sleep patterns. We do a lot of teaching. We support connections with many of the classes that we do, both of them educational, but art is one of them that's really connecting people together. And our Tai Chi and massage therapy is doing this, our Tai Chi and yoga classes are doing similar kind of stuff. Next slide. So financial, I just wanted to touch very quickly on this. Is a few examples of what we do to fund this. It's not always possible to have all of the services funded, but we use the standard EM codes for the normal services, and then we have all of these other mechanisms that you can see here to the right. The one that we really struggled with originally was the care navigation, to really use those available codes effectively to make it a viable model. So we're using currently the chronic care management codes or the principal care management code. And then now we can also use the community health workers can bill with the G0019 code, and all of the additional wellness services that we have, like the art classes are free. The Tai Chi classes are a donation-based $5 a class. So we try to do a lot of that. And then some of our behavioral health services are free because we train students in that space to provide behavioral health. And then we have philanthropy that mainly support the kitchen. So that's how we do this from a financial perspective. And I just want to make one point that the group visits that's normally seen within lifestyle medicine as a very important way of creating financial viability, we struggle a little bit with that because we find that older adults struggle to function like that in a team, in a group, to share some of their it's just hard to get them together and willingness to share so deep about their own health and mental health concerns. So we have not been successful with the group visits, but we are not giving up hope with that. Next slide. And now I am delighted to introduce you to Kamel, or I'm going to mess up this last name. I'm so sorry. Wagel, who's going to take us further.
Hello, everybody. Thank you, Drs. Friedman and Fall, for this rich content. I'm a geriatrician. My journey is in, I get to practice in a variety of clinical settings in geriatrics, and I've been observing my older adults. Their problem list in Epic or whatever medical record we use keep getting bigger, and we are not really making changes in the fundamentals of their lifestyle, which is a foundation for health. So I got to do the board certification of lifestyle medicine 3 years ago, and I've been integrating it in my practice. And I'll be touching in the last two objectives of today's talk. We'll discuss about key features of geriatric lifestyle medicine, including care models tailored for older adult population, and we'll discuss some practical tools and strategies. And I look forward to further discussion in our Q&A. So I want to look through this with the lens of two of my patients, my cases. So let's. It also illustrates a range of older adult that we get to see in practice. So introducing Mr. A. He's a 65-year-old man. He lives with his wife. and he has 2 children. They are in town. He has a college education, worked as a basketball coach, and just retired. His father died at age 77 due to cancer, and his father also had a poor quality of life due to diabetes complication. My patient also get to observe his mom die at age of 78 due to Alzheimer's dementia. He does not want to have complicated health journey like his parents, and he wanted to be available for his grandkids and children, and he wanted to live a good quality of life. That's his motivation to come to the primary care practice. He has type 2 diabetes, essential hypertension, hyperlipidemia, obesity. He proudly stated how physically active he stays. He does eat out half of the time, does not sleep very well, enjoys smoking cigars while playing golf, drinks 4 to 5 evenings a week, 3 to 4 beers each time. And his goal in life is his joy in life is his 5-year-old granddaughter, and he's very excited that he'll have another grandson soon. His health goal is to live long, healthy, and being able to enjoy his family. Now I want to introduce you to my another patient. She's Mrs. B, 82-year-old female who presents with multiple health concerns to the practice. She lives alone. She's a divorcee. She has 4 children. 2 of them are out of state. She doesn't get to see them often. 2 of them are live locally, but they are very busy in their own lives. She had high school education, worked as an elementary school secretary for 36 years. She has multiple health issues: hyperparathyroidism, chronic kidney disease, chronic back pain, osteoporotic vertebral fracture, chronic insomnia, occasional bowel incontinence, urinary incontinence, nocturia, insomnia. She takes 2 of her of PM over-the-counter medication to help with the sleep. She's mostly sedentary at home. She orders food online and utilizes packaged food and microwaves them. She has a poor sleep. She's socially isolated. She doesn't want to go out with her issues with pain and incontinence. She doesn't smoke or drink alcohol. Her goal is you like to resume her activities with her girlfriends and go to a museum, go to park, to be engaged in her community. So think through these 2 cases as I present on geriatric practice. You know, this slide is a busy slide, but let's start from the left side. This in the center of a geriatric practice is a patient, and there's always a caregiver. We call them patient and caregiver dyad. And typical geriatric practice team member include medical assistant, primary care provider, office staff, office manager, nurse. But there's also extended team member which are available as per need. They may not be located in the same site, but there is a collaboration with social worker, behavioral health therapist, pharmacist, physical therapist, occupational therapist, and a speech therapist. And I want to take our attention to the right side of the slide. A well-functioning geriatric primary care team is interdisciplinary, where team members work independently at the top of each members' scope of practice, with full collaboration, seamless communication, and shared decision-making in creating care plan for patient. So a typical geriatric primary care practice really collaborates well with the hospital, post-acute care, so they are part of the team helping out with this transition of care. They also collaborate with the home health team members. They are also collaborating with the community-based organizations like AAA, Alzheimer's Association, etc. And they also are fully in collaboration with the local community, park, fitness center, local older adult activities happening in the town. The next slide. And with the help of this team member, we, as Geriatric Practice, conducts a comprehensive geriatric assessment. This includes assessment of function. ADLs are like a basic function of every individual. We want to know how they are bathing, dressing, toileting, transferring, how continent they are, how they are feeding themselves. But if you think from the third column of this table, gives you an idea of integration with lifestyle medicine, and you can imagine when considering ADL function is extremely important to even do some lifestyle intervention. And this functional assessment touches multi-complexity, mobility, what matters most for the patient. The second assessment we do is instrumental activity of daily living. We would like to know how the person is functioning with the meal, finance, medication management, appointments, etc. And again, you can imagine this is such a critical part to understand person's function, and it needs to be considered when you are prescribing some lifestyle medicine intervention. Similarly, we touch base on vision and hearing. And again, these are critical to know before we prescribe lifestyle intervention. We do a nutritional counseling. We want to make sure are they getting adequate of balance food groups, and is there a food security? And this is also an important part of the lifestyle medicine as well. Next slide talks about further few assessment. One is a timed up and go test. We do this office test to check how persons moves. It'll give us an idea of a person's frailty, mobility, and also it can give you cues on what kind of exercise intervention you want to do for the patient. It touches based on the mobility part of this 5M. We do a cognitive assessment. And again, this is a foundational for interventions for lifestyle. We're assessing mind of the 5Ms. Similarly, we do depression, anxiety screening, tobacco, alcohol, substance abuse screening. And we also do a big amount of medication review. There is American Geriatric Society has Beer's criteria of potentially harmful medication for older adults. So we screen if my patients are taking any of those medications. Similarly, we look at other tools like a start and stop. These are some other tools to look at appropriateness of the medications. Are people getting medicine they're supposed to get? Are people getting medicine that are not supposed to get? With these tools, we optimize the person's medications. And we also, it also helps us what kind of lifestyle intervention to do to minimize pill burden or polypharmacy for the patients. Advanced care planning is an integral part of geriatric practice. We always want to know what is the plan, what's their goal, what matters most to them. And this is, as you can imagine, is extremely important for lifestyle intervention. I'll move on to next slide. And this table just gives you some example of how we can screen for lifestyle pillars in our geriatric practice. There you can find tools as tools that are very abbreviated and short, and also gives a good idea. And there are also very longer tools available as per your need to use. So there is the simple 24-hour dietary recall is a simple tool that gives you a good idea about a person's dietary history. There's also ACLM diet screening. There is a mind diet scoring that we can use. In exercise, we want to know how they are exercising, where they are exercising, with whom they're exercising, how frequently we're exercising, and there are different tools. Similarly, for sleep, we can assess how out of 7 nights, how many nights they get a good sleep. The moment you ask some open-ended question, then that's what opens the door for a solution. The moment I ask, sometimes I ask patients, how's your sleep? They say, I'm doing okay. But when I ask them, okay, tell me how many nights you slept in last 7 nights, then they say, I really slept good in 2 nights. So it gives an idea of a person's lifestyle pillars. Similarly, next slide highlights some assessment of other lifestyle pillars like high-risk behavior. There are tools to assess use of tobacco, alcohol, substance abuse. There's also a stress, assessing how what's the level of their stress and what is their strategy to cope with the stress. And I also always ask what's their social space. Do they have a social support system? Do they have a healthy social relationship? Are they socially isolated, or do they have loneliness? There are very quick screening tools available that we can use to assess this lifestyle pillar. And as you are aware, for all the lifestyle intervention, it's all about behavioral change, and we can't do it without assessing person's stage of behavioral change. We need to assess how ready they are for the change and how confident they are for the change, and use we should be using our counseling, either a positive psychology or motivational interview, just to help based on their staging. So going back to our cases, we had amazing success with those two examples. I know we didn't go deeper dive in each of the case, but I just to share the first patient, Mr. A, was essentially coming with the goal of prevention, and he had we kind of anchored in his goal of staying healthy, being available for family, avoiding complicated health issues with aging. So we discussed where he was really able to really latch on a variety of lifestyle intervention. He did a culinary medicine classes, silver sneaker program, diabetes prevention program, sleep hygiene. We screened for sleep apnea. He really thrived very well during in follow-ups. In our second patient, 82-year-old female with a multiple health concern, we did one incremental progress at a time. We medically tailored meals, personalized exercise program. We collaborated with social worker and community-based organization to have some companion program. We did some stress management, sleep hygiene, some physical and occupational therapy, and eventually she was able to go out a couple hours with her girlfriends and enjoy some museum, community activities, etc. So next slide is some strategy in how to incorporate lifestyle medicine tools in geriatric practice. Is we want to do the geriatric 5M assessment and lifestyle vitals in every pillars. And because we saw in this presentation how they are very well integrated, and we will need to assess the stage of change and counsel them accordingly. We need to do a shared decision making. We need to make our plan with the patient's active involvement, not a passive involvement. And we give us very specific time-bound goals that has details about frequency, intensity, type of activities. We do a written plan of care, and we select handouts. Some of my patients, they don't want to read, they like documentaries, so we can give some idea about what documentary can provide them some ideas. Some of my patients like to read books, so we can recommend some accordingly. Some of my patients want to listen to podcasts, so there are some. So we can meet patients' preferences in how they want to learn more about improving their lifestyle. Promoting community resources, we cannot. It takes a village to really support our patients and lifestyle pillars. Focusing on what matters to them, and utilizing electronic health record. And some of my patients are, even despite regardless of their advanced age, they are still able to collaborate very well and communicate well with the portal system, so we can use them. We really need to maximize teamwork. Sometimes I'm like a light in deer's eyes, like I have no idea what to do. I share that with my team, and my team always comes with some brighter ideas. So utilizing team huddles and teamwork is extremely important. Similarly, I touch base on some of the thing in patient handout, but I carefully design after visit summary for lifestyle. I give a food prescription, tips on reading food label, exercise prescription, etc., as per patient's personalized instructions. Addressing barriers is our next slide. Yeah, we can move on to next slide, Kelly. And then in addressing barrier, there's always comes up is there is no time to do this, and there are so many tools available, and even a very quick check-in with each of pillars. The moment you ask question, the patients will also it just opens the door for solutions. So and it doesn't have to be the provider doing everything. It is a team-based approach. So you can really leverage your team to assess all the lifestyle pillars. Then if there is a lack of multidisciplinary team, we really need to collaborate, find a creative way to do work asynchronously, maybe not in same time and place. And also communication. We need to really clearly define what each team member's role is and revisit in team huddle so we can maximize everyone's scope of practice. We cannot just prescribe our intervention and then follow up in 3 months, 6 months. We need to have a plan for follow up as per patient's need. And that can be quick check-ins or quick check-in by any of the team members, portal messaging. And we need to be aware of what resources are available in your local area. With this, I look forward to further conversation, and Kelly has some resources.
Thank you, Dr. Wegley. So as far as tools and resources, there are many available through the American College of Lifestyle Medicine. You can go through this QR code to get to the main webpage of our tools and resources. And just wanted to share some examples of the many different ACLM patient handouts that we have available. One is overactive bladder, another is constipation. Both of these may fit very well into a geriatrics practice, as is handouts on brain health and on the pillars, including this one on nutrition. ACLM also has a number of different toolkits, including shared medical appointment resources, and these are members-only resources. We did just launch a free culinary medicine program, so if you would like to use that QR code, it will take you to a series of over 15 hours of videos on culinary medicine. If you might be interested in joining ACLM, the QR code here will take you directly to our membership webpage. We do have a very robust geriatric member interest group that is currently led by Dr. Kamal Wegley, but then also Dr. Shandy Shaman and Christine Nesis. And their next meeting will be December 3rd. I wanted to give a shout out to the annual conference, which is coming up just next month, November 16th through 19th. The in-person will be near Dallas, Texas this year, or you can also enjoy the conference online. And if you might be interested in certification, you can join over 8,000 physicians and clinicians within the United States and globally that have become diplomates of the American Board of Lifestyle Medicine, the International Board of Lifestyle Medicine, and the American College of Lifestyle Medicine. And registration for the 2026 exam will open later this year and then closes on September 30th. All right, so now we have a few minutes to do a question and answer session with our speakers. So let's see if there are any questions.
Yes, absolutely. There are. A fantastic presentation. I think that there's a ton of interest in the amazing clinic that is located in Kentucky. In fact, somebody has asked if you're willing to franchise it because they want to see it in LA. But I think the real question is really back to the beginning. So this clinic has existed for 6 years, but how long did it take, for the planning? So like the time to market from concept to clinic open. And then there's some questions about funding such a, enormous effort.
Yeah. So you know how we some of you might be aware of the concept plan, do, study, act. Where you plan something and then you do it and then you study it and then you figure out it's not working right, then you change course and you start all over again. And that's literally how we did it. When we started and start planning the idea of doing an integrated clinic, that already started in 2015 when we started the institute. And there was no practice. We had a geriatric practice at Louisville, at the UL health system, but they were not at all integrating anything. Actually, the geriatricians did not really believe in anything like lifestyle medicine, because they were sort of the philosophy that this is end of life care. It's not, you don't really need to worry about exercise and nutrition and things like that. That's sort of not needed. And it took a journey, and it took a journey of conversation and building trust with the people, both the providers, but also with the upper management systems, to be able to do this. And then in 2019, we received a $5 million donation from a local bank and their family. It was a local family bank. They gave us the money to build out the space and dream what we wanted it to look like. And it literally almost killed me. However, it was a great experience to really, we said we wanted a kitchen, and originally it was a kitchen for the staff. And then, no, we needed a culinary kitchen. This is lifestyle medicine. And so that's how it developed. And so it was sort of organic on some levels, but we had a thought in our head, and it just took a lot of plan, do, study, act, where you know this, you want to do this, you're doing it incorrectly the first time, and then you keep trying until you get it right. So we're still working on it. It's still not perfect. The reimbursement, we started with being a clinic that's deeply in trouble. And then I started to develop a really good relationship with the chief operating officer of the University of Louisville Health. And he said, if you can make it an innovation space and you don't lose too much a year, I will support you. And we are now, after 5 years, learning the new methods of how do you bill for all of these services. Our latest one is the Principal Care Management Codes, and it's starting to work. So we are not so much in debt anymore. So it's a journey, and then you have to use philanthropy a lot, and you have to some of the things you just have to do self-pay, and volunteers and students.
Right. I think it is very interesting that from a philanthropy standpoint, you have a bank involved. I think people often forget that, when people live longer, they have more time to invest. And so it's really the banks and those kinds of institutions that love this type of approach in their communities. So that's wonderful. I have another question about the team setup. Several people noticed that health and wellness coaches and registered dietitians weren't necessarily a part of the team. And can you kind of talk through that?
Yeah, the reason we don't have a dietitian is one simple reason, and that is that we don't have a dietitian program at the University of Louisville. So we are working with, we are just now creating collaborations for our kitchen with, there's 5 dietitians that's working at a local hospital, Norton's, that's close to us, that do some training in our hospitals, and they are willing to work with us on the kitchen. So that's why we don't have them. The health coaches, that is something we are working on right now, because we have the exercise physiologists, we already have a nutritionist, well, not a nutritionist, but the person who's doing the culinary medicine classes. We do have a community educator that I probably forgot to put on the list, that's doing a lot of the health coaching. She's doing my Life Matters classes remotely. She's also doing it, we call it flourishing together is sort of based on the microclinics model, where we have sessions that last for 6 to 8 weeks, where we do health coaching. So it's embedded in the work that we do. I probably just didn't mention it.
No, that's brilliant. Susan and Kamal, some of the questions are also about effective strategies to sustain engagement from these older populations. So basically, if the clients are resistant to change, and you do have some common barriers for older adults that, you know, basically can be stereotyped across this population. What are some effective strategies to really get them engaged in lifestyle medicine?
Yeah, I think this is where both the framework of the 5 M's and of lifestyle medicine in general really is important. Really trying to understand what the patient's goals are, and really trying to bring it back to what those goals are, because I think that can be really motivating. And then the other piece of it, I would say, is just understanding where they are in terms of stage of change. So if people are really pre-contemplative, then educating them on the connections between the different lifestyle pillars and their conditions can maybe help to move them in that direction. But I think there is oftentimes an underappreciation for just what an incredible impact changing one's diet can have in terms of overall health and well-being. And so, it's certainly not something that we're taught a lot in our medical training, and so it's hard. It doesn't get passed on to patients a lot, and sometimes just pointing out that within a couple of weeks, they can really have more energy, they can have less pain, they can sleep better, they can have better mood. A lot of these real quality of life kind of things, I think can change pretty quickly when people change how they're living their lives. And so just kind of making that point, and then again, bringing it back to their goals.
Excellent. Dr. Kamal, do you have anything to add?
Yeah, always prior to lifestyle medicine, I think I underestimated my patient. I think there is so much eagerness to change, to work on their lifestyle. But I think the resistance is also when we are actively prescribing them what to do instead of having patient be on board. Just like Dr. Friedman mentioned, focusing on what matters to them, what is their goal, what is their joy of the life, what they want to do, and really doing a comprehensive assessment. The moment we know what matters to them, the 5 M's, the lifestyle pillars, we know where it can help us prioritize. And if you are talking to a patient who is depressed and have a lot of social isolation, then it's impossible for the patient to start an exercise program, right? And we need to work on the moment you do a comprehensive assessment, you need to work on some maybe breaking the cycle of social isolation and engagement and addressing depression, and maybe there will be time to work on other pillars. So it's a journey for every individual, personalized journey for each patient. Mm-hmm. It's a shared decision making and prioritizing.
Yeah. That's wonderful. Kelly, we just have a couple of minutes. Do you want to kind of wrap things up for our audience?
Absolutely. Thank you, Leslie. And Drs. Friedman, Fall, and Wakely, thank you so much for sharing your expertise with us today. If anyone would like to reach out to ACLM, the information is here. Please join us on social media and explore our website. Thank you all and have a wonderful rest of the day.
Great. Thank you. We'll see you next time.